Greetings, everyone. Welcome to the 231st session of the online Optom Learning Series, OOLS. And for today's session, we have with us Anand Trivedi. Anand is an optometrist with over 6 years of experience of being an optometrist, a clinician, as well as a researcher. He has done his Bachelor of Optometry from the School of Optometry in Dahod, Gujarat, India, and also went ahead with his passion and completed a fellowship in pediatrics strabismus with amblyopia management from Drashti Netralaya. Just having conversation with Anand just now, I also came to know that he was the first one to kind of publish a case report in the Indian Journal of Ophthalmology regarding this topic. So we are very pleased to kind of share with us this experience on how can this particular instrument and basically the knowledge of perceptual learning with hand-eye coordination can be useful for treating patients with amblyopia. So welcome, Anand, to our platform, and thank you for spending your evening with us, sharing this topic. And I will now leave the screen time to you, please.
Yeah, thank you so much. Thank you so much for giving me this opportunity. Everyone, my name is Anand Trivedi, and I'm an optometrist with over 6 years of experience and optometrist, and I have completed my study in optometry, and I have also completed my fellowship in pediatric establishments and amblyopia management. And I'm delighted to be here today to discuss the fascinating topic of perceptual learning with hand-eye coordination as an effective tool for managing amblyopia. So let's start. So we will talking about the amblyopia and orthoptech, and also we will talking about the definition, process of vision and perception, current management, and the last one is future trends in therapy. So let's discuss about the definition of amblyopia. There are two definitions. The old definition is the basic definition. It's reduced visual acuity with a difference of two lines of acuity between the two eyes on the vision chart assessment. The new definition have we defined it yet. Perhaps it has to be defined based on excluding other causes for visual acuity reduction. Perhaps cerebral changes possibility defined by fMRI findings. So, amblyopia is a serious condition resulting in monocular impairment of vision. Although traditional treatment improves vision, we attempt to explore the result of perceptual learning in this study. Okay. So the gold standard treatment till now has been occlusive therapy for the amblyopia. So what are the common causes of amblyopia? There is strabismus, anisometropia, hyometropia, and visual deprivation. And the other visual deficits, the hyperacuity, shape perception, spatial interaction, contour integration, and visual counting, reduced or absent stereopsis, and motion processing. Okay. So the knowledge-based amblyopia, the prerequisites for understanding the amblyopic eye for the researcher and the ophthalmic clinician, there is a neuroanatomy, neurophysiology, neuropathology, and all the ophthalmic skills. Okay. So amblyopia is a cortical developmental disorder secondary to abnormal visual inputs in each eye early in life during the cortical plasticity stage, wherein dissimilar action potential, amplitude, or time or both generated in the retina reach the cortex. These cortical changes entice the visual cortex to prefer one eye over the other, leading to several function deficits in the eye. This includes altered visual functions such as decreased vernier acuity, impaired contrast sensitivity, especially in detecting high spatial frequency stimuli. Okay, and impaired motor signals such as hand-eye coordination and spatial localization. These defects can be unilateral or bilateral. Amblyopia is the most common causes of monocular visual impairment that affects 2 to 5% of the general population. So what are the risk factors for amblyopia? There are premature birth, small for gestational age, developmental delay, and having a first degree relative with amblyopia. Some studies have reported that environmental factors including maternal substance abuse during pregnancy is associated with an increased risk of amblyopia or strabismus, while other studies have reflected them claim. Okay, so what are the cortical aspects of vision? Vision has dichotomous process, a well-organized process from the retina to the cortex. There are parallel streams with horizontal connection. There are top-down and bottom-up impulses. The top-down streams modulated the bottom-up impulses from the retina to the V1 layer. Okay, if you like look at the picture, you realize that the first to stop in the brain is the lateral geniculate body from the ganglion cells in the retina. There are parvocellular cells. There are magnocellular cells in the retina, and there is a nasal retina and the temporal retina divided with respect to the fovea, and the first stop is in the lateral geniculate body. Look at the picture. The magnocellular cells discharge on two layers, 1 and 2, as the parvocellular cells discharge on four layers, the 3, 4, 5, and 6. This is the first discharge. Do not assume the lateral geniculate body is simply a relay station, not really. And that is the dichotomous pathway, the magnocellular cells and the parvocellular cells. The magnocellular cells is the peripheral area and the parvocellular cells is the central area. And they go to the ventral part of the lateral geniculate body for the magnocellular cells is layer 1 and 2. And the central area for the parvocellular cells, they go to the dorsal part of the lateral geniculate body, the layer 3, 4, 5, and 6. So we're talking about the visual pathway structure and the silent features in them. So retinal fibers go to the lateral geniculate body, and from the lateral geniculate body, there is a complete segregation of the right and left eye fibers, and parvo and magnocellular fibers are also equally segregated, and from the lateral geniculate body. The red optic radiation go to the lowest level in the occipital cortex, that is the V1 layer. In V1, the magnocellular cells and parvocellular cells discharge separately. The magnocellular cells go to layer 4C alpha, and the parvocellular cells go to layer 4C beta, as shown in the picture here. It's important to understand this difference between the difference in the place where the magno and parvocellular cell discharge in the brain is very important to understand, because in amblyopia the problem is with the parvocellular cells mainly, and so the problem should at level 4C beta. Understand? So now we will talking about, so as I already mentioned, the lateral geniculate body is not a simple relay station. Only 30% of retinal impulses are forwarded to the cortex. After modification, lateral geniculate body also receives corticogeniculate modulating fibers from V1. Okay, so this is the dichotomic, doesn't stop there, extend further. Okay, the magnocellular cells are involved in wear of vision, and they go to the supratemporal supraparietal area. Okay, so we will talking about the cortical aspects of vision. So where is the vision and what of the vision? And the parvocellular cells are involved in what of vision, and they go to the infratemporal cortex. Okay, there are 6 layers of visual cortex. Layer 4 has 3 layers, A, B, and C. Right and left eyes are segregated in layer 4 as ocular dominance columns. The M fibers end in layer 4C alpha, and P fibers end in 4C beta. M cells are for spatial vision, the wear of vision, and the P cells are the visual details and definitions, the what of vision. Okay, so what are the cortical aspect of vision? You may ask me, why is it important to all these things when you use orthotech? So answer lies in understanding further. When you treat amblyopia, the V1 is the lowest connection, and some M fibers also reach the mild temporal area directly. Understand? So this is the complex connection of the occipital cortex with the rest of the part of the brain. Okay, so we will talking about the amblyopia. It is a brain abnormality, not only an eye abnormality. Okay, in amblyopia, there is a functional structural deficits in the visual cortex, and the MRI and fMRI scans do show us the way forward. This shows the fMRI findings in picture 1, where the patient is fixating on the normal eye. You realize that both the occipital cortex is stimulated. In picture 2, when the patient is fixating on the amblyopic eye, you can see the reduced blood supply, and that is because of reduced occipital blood supply to the brain in the amblyopic eye. Understand? So bold scans do show show a drastic reduction in the oxygen consumption in the occipital cortex in amblyopia. And also PET scan shows the same things. Okay. So what are the treatment of amblyopia? The gold standard treatment is occlusion. Okay. So there are the treatment options for amblyopic in children, that is optical correction of significant diffractive errors, patching, pharmacology treatment, diffractive surgery, and alternative therapies. Okay. Recently, computer exercises have been introduced where both the eyes as well as individual eyes can do this exercise, and again, this improve the vision centers of the brain. Both these exercises have followed a bottom-top approach wherein you stimulate vision and therefore the vision centers develop as a result of that. So first the eye is stimulated or the retina is stimulated and the last is brain is stimulated. Understand? So we will talking about the top-down impulses. Okay, the top-down impulses originated in the prefrontal cortex and alter the attention mechanism, which in turn affects the right cortex. There are two attentions in this instrument: overt attention and covert attention. The overt attention is defined as the moment when the peripheral stimulus draws the attention of the eye and ensures foveal fixation. And the covert attention is when the patient is fixating on the central light and still can see the peripheral lights. Both the attentions stimulate the lateral occipital cortex via the top-down impulses. Okay, the above motor and sensory aspect of vision are the principles used for developing the orthoptic magnocellular stimulator (OMS), an advanced treatment modality for amblyopia. And this techniques follows a top-bottom approach, which means that when we perform the exercise, multiple areas in the brain are stimulated, which in turn will develop the vision centers in the brain. Okay, so we will talking about the orthoptic magnocellular stimulator (OMS). The instrument has three rows of light, LED light, and the central one is red in color. The lights come on for 300 milliseconds and are off for 150 milliseconds. Patient fixate on the lights and point as it with the laser point. The patients are seated at a distance of 1 meter from the mechanism from the machine. Procedure is conducted for 30 minutes with both eyes open and with weak eyes only open. This is the photograph of Mercer orthopedic instrument. Okay, so the exercise has two parts. We're talking about part one. In the first part, the patient has to look at the wait. I'll show the video. So in the first part, the patient has to look at the light but follow the peripheral light as they come on. These peripheral lights come on for about 300 milliseconds. The patient starts with the latter eye while the weaker eye is covered, and he performs the exercise for 2 minutes. After that, the patient covers the better eye and performs the exercise with the weaker eye for about 20 minutes. After that, both eyes are open and the exercise is performed for 5 minutes. So good eye for 2 minutes, lazy eye for 20 minutes, and both eye for 5 minutes. Okay, so we're talking about the part two. In the second part, the patient has to again look at the central red light and not move the eye from there. The peripheral lights will come on and go off randomly. The patient has to count the number of times he see the peripheral light while he is looking at the red light. So he first does the exercise with the other eye and count peripheral lights up to the 400 times. He then does the exercise with a strong eye covering the weak eye and he counts up to 200 times. The peripheral lights coming on, and then the opens both eyes and count the peripheral lights up to 200 times. That conclude the second part of the exercise. So the exercise or sessions lasts of about 40 minutes, and you should note that the number of times that we ask the patient to count the light would depend on the severity of amblyopia. Your therapist can decide the duration of therapy based on the child's vision and severity of amblyopia. Okay, so that are the results. This method was applied in 47 patients, 23 women and 24 men with a mean age of 14.11 plus or minus 7.13, 23 years. The mean follow-up period was 17 days. The prior to the procedure, 28 patients were orthophoric, where after the procedure, 30 had orthophoria. The significant difference was detected for distance and near in the deviation by prism bar cover test. Nonetheless, no significant difference was observed between the two age group for distance as well as near. Visual improvement was also observed in the older age group. Okay, strabismic amblyopia was detected in 48.9% of patients. Refractive amblyopia was noticed in 46.8% of patients. However, no significant difference was observed in the visual outcomes following training. But the pre and post-treatment vision, near and distance stereopsis, and contrast sensitivity differed significantly in two subgroups. Okay, so why orthoptic works so well? You know, to understand why the orthoptic works so well. So rapidly improving the amblyopia, you need to know some basic facts. You already know that from the retina, the impulses go to the LGN, lateral geniculate body, and from there they go to the cortex, and from there the impulses come down right up to the retina. Okay, so the sensory cortex in turn in closely connected to the motor cortex is an orderly fashion foveo-cortical fidelity. The retinomotor value is decided by the distance of the peripheral retina point from the fovea, and foveal stimulation does not elicit any movement of the eyes. The retina between the fovea and the stimulated peripheral retina point is suppressed during the saccades. At the end of the saccades, the fovea is already altered about the peripheral object of interest due to a close connection between the M and P cell pathway at various levels. Okay, this is the principle that is exploited by the orthoptic machine. Okay, you see here from the retina, the magnocellular cells go to the LG lateral geniculate body, LG1 and 2. From the parvocellular cells go to the 3, 4, 5 and 6 layers in the lateral geniculate body, which is not a simple relay station as I already told you. Okay, so supposing the retinal problems and the LGN problems, lateral geniculate body problems are the causes of amblyopia, we are not doing anything to treat these two areas. But remember, the top-down impulses come right up the retina because LGN also receives corticogeniculate modulating fibers from V1, which are usually but not always inhibitory. Okay. So the parvocellular cells go to the layer 4C beta and the V1 layer, and the macrocellular cells go to the 4C alpha and V1 layer. As I already mentioned, and parvocellular cells from 4C beta in V1 layer, they go to the infratemporal cortex, which is responsible for what of vision, and most of the suppression and most of the problems in amblyopia is at this level, that is layer 4C beta in this synapse. Okay, whereas magnocellular cells are not suppressed because they go to the 4C alpha and V1, and from there they go to the superior parietal cortex, which is responsible for where of vision. Okay, so the magnocellular fibers and parvocellular fibers are interconnected throughout, and that is how you know where is vision and what is vision, both M and P cells pathway, and is what is called as primary posterior parietal cortex, PPC. And this PPC is very important. Okay, because that is where the attention area is stimulated. PPC has an attention area and has a secondary area, and these two area again interconnected. If the attention area is strongly stimulated and the secondary area is inhibited, the secondary area is strongly stimulated and the attention area is diverted to the peripheral object of interest. This is very important to understand. Okay, so the PPC receives the sensory afferents, visual afferents, auditory afferents, somatosensory, and autonomic afferents, and therefore it is called as Global Sensory Motor Integration Center. Okay, so as I mentioned there earlier, the PPC has attention area and secondary area. which are again interconnected and strongly stimulating the saccadic area, sends negative impulses to attention area, but it sends positive impulses to the layer 4C beta in V1 via the attention area. So this is very important to understand because our top-down impulses come from the attention area in the parietal cortex and they go to different parts of the cortex including to V1. Strongly stimulated saccadic area makes the eye movement. A strongly stimulated attention area prevents the eye from moving. So there is a close balance between these two areas in the parietal cortex. Okay. So peripheral retinal point, when stimulated by sudden appearance of light, the eye make a saccadic movement in a specific direction and specific amount. Direction and the amount of the movement is determined by the position of the peripheral stimulated point from the fovea due to foveo-cortical fidelity. Okay. The further away from the fovea, the retinal point is the greater is the movement. Closer to the fovea, lesser is the movement. And right at the fovea, the eye does not move at all. So hence, the fovea has zero retinomotor value. A point further away from the fovea has greater retinomotor value, but it has a least visual acuity values that important to remember. So, sudden appearance of the light leads to stimulation of the saccadic movement, which is associated with stimulations of the fovea in V1 via top-down impulses, and the same time there is suppression of the retinal areas between the fovea and peripheral stimulated retinal point, and to avoid emerging effect. Okay, so, repeated stimulations of the macrocellular cells leads to repeated stimulation because of the prosaccade is associated with maximal stimulation of the V1 area via the attention area in the parietal cortex. So, this is the important to understand that when you use orthoptech, there is repeated stimulations of macrocellular cells and repeated stimulations of the fovea, and these stimulations of the fovea by the top-down impulses coming from the parietal lobe avoid the suppression at the level of sinuses of level 4C beta in layer V1 because the top-down impulses and before the synapse, in the synapse and after the synapse, V1 4C alpha, therefore the top-down impulses improve the vision a lot more rapidly also in amblyopia. In our clinic, nearby 90% of the patients covered from amblyopia, the vision improves, diopsis improves, there is an improvement in hand-eye coordination, the improved self-confidence, reduced nystagmus. And what are the conclusion? The perceptual learning with hand-eye coordination is an effective method for managing amblyopia in older children. The technique is utilized irrespective of age and the visual outcomes has improved in patients with orthophoria. Thank you for your attention. We believe and we sign. So our goal is 6 by happy patient. Thank you so much. Thanks a lot.
Thank you so much, Anand, for sharing. That new technology. Not so new. It's been in the market, as you were saying, for quite some time. But a lot of us may or may not have the knowledge about it. So thank you for sharing your experience on how this really works and uh, how beneficial it is for patients. So I saw that you have done a small study in your clinic where you found that a lot of, almost everyone improved in terms of not only the vision but their binocularity and their phoria status and tropia status also became better. So that's great.
Exactly. Yeah.
Yeah, I think Anand, you wanted to show the video on how the thing works. If you can show, because you did mention that there are two parts, and first part is basically look, yeah, this one, yeah.
Yeah.
So the first part is where the
Patient
patient
has
is actually having.
look at the light, but follow the peripheral light as they come on. This peripheral light come on about 300 milliseconds like this. Wait, I'll show you the video.
Ah, yes. Okay.
Yeah. Okay. This is the part one. The patient starts with the better eye while the weaker eye is covered and he performs the exercise for 2 minutes. Okay. After the patient covers the better eye, cover the better eye and performs the exercise with a weaker eye, amblyopic eye for about 20 minutes. After that, both eyes are open and the exercise is performed for 5 minutes. Okay. This is the part one for this instrument. What the part two? I'll show you the part two.
Yeah, sure.
This is the part two. We are counting the lights. This is not for the
Okay.
laser light. Okay, we are counting, not follow for the light. Okay, so the patient has to again look at the central light and move the eye from there. The peripheral lights will come on and go off randomly. The patient has to count the number of times he see the peripheral light will while he is looking at the red light. Patient is looking at the red light and counting the peripheral light has turned off and on. Okay, so the first does not the exercise with the weaker eye and count the peripheral lights up to 400 times, and then does the exercise with a strong eye covering the weak eye, covering the amblyopic eye, and he counts up to 200 times the peripheral light
Okay.
coming on, peripheral light coming on, and then the open both eyes and count the peripheral lights up to 200 times. For the weaker eye, count 400 times. For the good eye, counts 200 times. For the both eyes, count 200 times again.
Okay. And this entire process kind of takes about 40 minutes,
40
roughly.
minutes,
40 minutes.
roughly. Yeah, exactly. 40 minutes.
Okay, great. Awesome. So, yeah, that clears some of the doubts which came up on the chat. Any special requirement to have any uh, the screen requirement? Is there any special requirement, or it can be used on any of the screen, or does the company supply the screen with the software?
Yeah, exactly. I understand your question. Actually, the prerequisites for the instrument is the low illuminations area for the dark room area. Okay, and there are screens for the there are small screen the company will provide. Okay, the main author for the instrument is Dr. Santana Gopal. He is from Bangalore, and the instruments will provide from Bangalore. Dr. Santanan Gopal's sir says that the we will prerequisites for the instrument is laser light, for the laser light and the machines, orthoptic machine. For it has been six one central light, one central red light, another peripheral white light. So there are the prerequisites. First, we will patient has to come in our clinic. Patient has to come in our hospital. We will check all the examinations. We will check the vision. We will check the refractive error. We will check the stereopsis. We will check the cover test, uncover test, prism bar cover test. If strabismus has been present, if not, then okay. Then after we will diagnose the amblyopia. We will check the retina and all. Okay, then we will diagnose the amblyopia. Then we'll do the process for this session. There are per day 3 sessions, 40 minutes. There are 3 sessions per day. Okay, the first one session is 40 minutes. The second session is also 40 minutes. And the last session is also 40 minutes. The exercise will do the 17 days these for these instruments. Okay, we'll do the 17 days.
Okay.
Understand? Yeah,
So it basically the instrument is provided by the inventor himself, and then you have to go ahead and use
yeah,
that
exactly.
instrument. So we don't have to have a special screen or something like that. Okay.
Yeah, exactly.
Uh, yeah. The other question is, you did mention about the perceptual skills. Do you have any idea, or if we don't have any specific test to measure or to quantify, is there any way you can see if the perceptual skills have improved?
Uh, uh, the mainly wait, I'll ask you the answer. Mainly the handwriting is improved for the patient. We will check also after the session. We will check the handwriting for the patient. Every session we will check we will check the handwriting for the patients. After the 17th session, after the 17th session, We will check the handwriting, and we'll check that is the handwriting is improved for the patient. This is the hand-eye coordination, and patient's confidence and confidence is also improved after this exercise, after this session.
Right.
Yeah,
And did you compare these results with orthotech with other traditional methods, for example, patching? Do you find that it is much better, or have you have any experience of doing any comparison?
yeah. Before this orthoptech, we will provide the occlusion therapy also, patients occlusion therapy, because it's common therapy for the all the emblyopic patient. Okay,
Yeah.
and there are lots of studies from there. Okay, but this is the advanced technology, and this is the new technology, and this is game changer technology for the occlusion therapy patients can do does or not for that, but orthoptech is compulsory to come and for the treat the amblyopia, and we'll do the process for all the process before the must exercise, and we'll ask the patient how to do that, how to cover that, and there is a good result after the orthoptech we will use after the orthoptic machine. There is good results from there, and
Okay.
I think orthoptics is best as compared to other exercise. I think
I
so.
see. So do you
Yeah,
still ask
this
your
is
patient to continue?
this is rapidly improvement for the vision.
I
Okay,
see.
as compared
Okay.
to other therapy, this is rapidly improvement for the vision, and also patient has orthophoric and orthotropia. We will check all the examination and we'll improve all these things.
Okay.
Understand? Yeah.
Right. So do you still continue if, let's say, the patient is undergoing this treatment? Do you still
Yeah.
continue patching? Do you ask patient to do patching at home, or no need to do patching at home?
No need to pay, no need to do patching after the exercise. After these 17 sessions, we will ask the patient for the follow up, 17 days follow up, and we'll check we will check the other examinations. We will check all the examination again, and
Right.
again we'll check the vision is improved or not. Okay, then after if the patient vision is improved, when I check, I think I know, I'll check one patient, the vision is the 7 years old boy. Okay, 7 to 8 years old boy, and his vision is 660 for the right eye. Okay, and after the exercise, after the 14 days, we will check the vision. The vision is 69. We'll check after we will ask the patient. The follow period is 17 days. Again, patient come for this after 17 days. We will check again the vision. We will check again the vision, and the vision is also 69. After 3 months, we will check again the vision. The vision is 69. It is not decrease the vision, and
Correct.
there is no need to after therapy for the occlusion. Also, there is no
Right.
need for
So,
that.
so basically, what you're saying is follow up is very important after
Follow up
the.
is very important for that. Yeah.
Correct. 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 Yeah. So the next question is, I think you said about 17 sessions it takes. Is it like the minimum? Is there any number, or it depends on the condition? Is there any
Uh,
specific number of sessions?
No, it depends on condition. Your therapist can decides after check the eye and about that. After your therapist has been decided, yeah, how
Correct.
many sessions can provide for the patient.
But let's say in your experience, in on average, how many sessions do
Yeah,
you think
exactly.
is good
I'll
enough?
check one more patient. Yeah, I'll tell you. I'll check one more patient. The patient has nystagmus, and also I think, yeah, the patient has nystagmus, and the vision. Yeah, patient age is 12 years old, female. Okay, and the nystagmus, the vision is 636, around 636, I think, and we'll took the we will ask the patient. The exercise is required for the 3 to 4 days only because of the nystagmus. है ना? Nystagmus is improved, but vision can't improve for that. Yeah.
Okay.
So yeah, this is for example. If any other retinal condition, any other retinal problems, we will diagnose all the examination. Then after your therapist can decide exactly what we can do. Yeah.
Correct. Yeah. Yeah.
First we will check all the examination. Then after we have to decide exactly what we can do.
Right. Yeah, so it's basically pure amblyopic cases can be treated without, I mean, the definition of amblyopia is you shouldn't have any underlying eye disease or pathology, right? So
Yes,
that we
exactly.
can't do much, correct?
Yeah,
Uh,
exactly.
Awesome, great. And any idea in, any experience of squint being treated? Is it more of exo is more treated or iso? Any thoughts?
Yeah, I check both the patients. I'll check both the patients. I'll share you my experience. I'll share you some cases. Actually, one more patients. Actually, wait, I'll check it in my mobile. I'll write down the patient's name and all.
Uh-huh. Yeah. So you have seen many patients, so you
Many
probably,
patients.
yeah. So okay, great. So,
Yeah, it's a 12 years old male, 12 years
mm,
old male boy. He has esotropia. Esotropia for the prism diopter, 14-degree prism diopter. Esotropia, 14-degree prism diopter, prism bar cover test. For the distance and near also. Okay, after the exercise, we will check again the prism bar cover test. We will again the cover test and Horsburg test. After the 17th session, the prism cover this PBCT, the squint is less. Okay, the 7 degree of PBCT,
oh,
almost 7 degree of PBCT, 7 prism diopter, prism PBCT. So
okay.
it can be improved in studio. It can be improved in squint vision. After we will check the studio depth perception. The depth perception stereopsis is also improved in these patients. Before the exercise, the stereopsis is 400 seconds of arc, and after the session, the stereopsis is 80 seconds of arc. This is the case, one case for the squint for the
Right.
esotropia. I can't check the esotropic patients, but we'll
Yeah,
check in
but so,
future.
so basically you are trying to say that it does help in all type of squints, right?
Yeah, exactly. Yeah,
Awesome, great. Somebody, just to clarify, neither Anand nor we have any financial interest in the product. We are just sharing this with you. I mean, Anand is not getting paid for sharing about Optotech, nor is OLS. But somebody wants to know if you have any contact with the manufacturer or the inventor. Do they provide any demo or anything? Do you have their email which we can share with the attendees or their contact?
yeah. I'll share all the details in your mail ID. I'll
Sure.
share. Yeah, the manufacturer is Dr. Santanan Gopal, sir, and I'll share the contact number also.
Yeah, we will be happy to connect you with them and you can take it further. Yeah, just to keep the thoughts clear. Awesome, great. And yeah, I think we have taken almost all questions. One last question is: Have you
Yeah,
tried
sure.
doing this with other vision therapy software which are available in the market? Have you
Yeah,
done any comparison, or you have only this one in your clinic? Do you have experience with others?
yeah. I listen to other instruments like binocle and all about it. Yeah. So I don't use these other instruments. I have only orthoptech,
Okay.
so I can
Yeah, yeah,
use only
fair enough.
orthoptech.
Yeah, yeah, you can't have everything. I mean, this works best for your patients, and your experience in using it. So that's great.
I Yes, thank you so much for that. And I'll also share my experience in Journal of Ophthalmology websites, IGO. You can
Yeah.
check it for that. And my article was also published in IGO in this topic.
Yeah, just as a reminder, we have the Euroschool India coming up very, very soon. There's about 8 days left for you if you are interested to learn about scleral lens fittings, troubleshooting. If you are a beginner, if you are on intermediate or advanced level, I think this workshop will have something for everyone. It is happening in India. at two locations on the 18th and 19th of May. Those are going to be the hands-on workshop on the 2 days. But prior to them, we also have online sessions where we will do the theory and understanding part of the concepts about scleral lenses, and we'll spend the entire day. The 18th of May is happening in Mumbai, and the 19th of May at Hyderabad, where we will do the workshop live hands-on session. So if you are interested, we are having up the registration to be closed up by about 8 days from now, 7 to 8 days from now. So if you are interested, please contact us, or you can go to our website, and the details will also be shared on the chat for your registration process. So thank you, Anand. Thank you so much for joining us and sharing your expertise. Thank you, everyone, for attending the session. You can also scan the QR code, which is up on the screen, for the feedback. And we do have session planned over the next week. We will send you the details, and we'll see you there. Until then, take care, be safe, and hope to see you during the next sessions. Bye-bye.
Yeah. Bye. Thank you so much.
Thank you, Anand. Bye-bye.
Yeah. Bye.